As you all will know, pituitary adenomas comprise 15% of all intracranial tumor, and in autopsy specimens, approximately 18 to 27%. So due to some endocrinological dysfunction, we can divide it into functionally active and non-functional pituitary adenomas. And they usually, regarding some space consuming, they can cause disturbances due to compression on surrounding anatomical structures. So from 1982 to 2020, we have more than 2,500 patients with pituitary adenomas. This is a long time period, but Croatia is a small country, only 3.5 million people. So in this surrounding, this is actually a pretty large series. So during surgery, signs of recent or old hemorrhage were found in 90% of adenomas. And of course, some patients had a clinical picture of pituitary apoplexy with all the symptoms that are included into it. Regarding the clinical manifestation, almost 60% of patients were asymptomatic, and 41% had some clinical picture. Slowly progressing clinical picture was found in 21% of patients, and acute was found in 20% of patients. In 29, almost 30% of patients with pituitary apoplexy have some serious clinical symptoms. In all series of 2,500 patients, only 5.6 of those had some serious clinical symptoms that can be connected to pituitary apoplexy. And then these symptoms can be divided into chiasmal syndrome, or some cavernous sinus syndrome, or some consciousness alterations, hemiparesis, meningeal syndromes, or even lethal outcome if some heavy endocrinological disturbances occur. Mild to moderate clinical symptoms were present in 70% of patients, and these are usually some headache or vertigo, nausea, vomiting, some visual disturbances. Regarding the age and gender, slightly more predominance of male, some 53% of patients, with a median age of 44.7. Pituitary apoplexy is due to intratumoral bleeding, usually were found in 22% of cases, or some ischemic event into the adenoma, 10% of cases, or some ischemic event followed by hemorrhagic necrosis. Predisposition factor that we found was the reduced blood flow through the pituitary gland and adenoma. Some blood pressure dropped in the patients due to comorbidity. Some during diagnostic tests, pituitary stimulation, then coagulation disturbances, and taking the medicamentous treatment, especially the bromocriptine in prolactinomas. In 45% of patients that had pituitary apoplexy, they were hypertensive. 32% of apoplexy cases had some prior respiratory infection, usually with strong coughing and sneezing, and 65% of patients with apoplexy presented actually as a first syndrome. Apoplexy usually increases suddenly the volume of the adenoma, and the chiasm and both anterior cerebral arteries are pushed cranially, while usually the carotid artery and the cavernous sinus structures being more pushed laterally. But incidence of the chiasmal syndrome in pituitary apoplexy is far more often, 22 to 1, in regard to cavernous sinus syndromes, due to, of course, more favorable anatomical relationship. The chiasmal syndrome is usually connected with visual deficits. This one is a case of the pituitary adenoma with apoplexy, with simultaneous chiasmal syndrome and cavernous sinus syndrome. As you can see, this is the MRI before surgery and after the surgery. Also, I'm sharing you some cases that we collected during years: pituitary adenoma with hemorrhagic necrosis and some subacute developing apoplexy. MRI, again, before transphenyral surgery in this bigger macroadenoma, and MRI after transphenyral surgery showing a good postoperative outcome. Also showing the macroadenoma, a big macroadenoma with MRI 2 weeks after the pituitary apoplexy with mixed signal inside of the adenoma and signs of intratumoral bleeding. Also rare case in the patients with apoplexy in the macroadenoma with chiasmal syndrome and Foster-Kennedy syndrome that actually developed simultaneously in this patient. Also acute headache without any neurological symptoms in case of apoplexy in the adenoma. Presentation of a gigantic adenoma with hydrocephalus, also with signs of bleeding, and some rare cases of thrombosed carotid artery aneurysms with signs of conjoined adenoma, also with increased factors of intratumoral bleeding. This is a case of ischemic adenoma infarction with sudden headache and chiasmal syndrome due to compression of the chiasm. As expected, pituitary apoplexy was found in macroadenomas, in tumors with extracellular expansion and in tumors with invasive character. We did not noted any specific histological pattern, so we didn't found on pathohistological examination increased vascularity, hypercellularity, polymorphism, and mitosis. And usually in adenoma, blood vessel walls, especially basal membranes, were thicker than in the healthy pituitary tissue. Some proliferation factors like Ki67 or interleukin showed increased growth and invasiveness, but no direct apoplexy predilection. We found pituitary apoplexy in 53% of non-functional adenomas, usually due to their growth and sudden or ischemic event or some necrosis in the non-functional adenoma, 28% in prolactinomas, 17% in somatotropic adenomas, and 2% in adenocorticotropic adenomas. Regarding the endocrinological status in patients before surgery, they were having normal pituitary function in 32%, or some different types of pituitary dysfunction, as like in the example, partial hypopituitarism in almost 50%, panhypopituitarism without diabetes insipidus in 30%, and panhypopituitarism with diabetes insipidus in only 4% of patients. So treatment with patients presenting with pituitary apoplexy and acute clinical symptoms is corticosteroid high dose and urgent surgical treatment. And we did this in majority regarding the transphenyral approach. And these are some intraoperative pictures showing upon opening the cellular membrane, the hemorrhagic tissue, tumorous tissue prolapsing. And this is the intraoperative photo of a blood clot mixed with tumor upon extraction of the bleeding adenoma. Of course, in some cases of larger adenomas with supracellular extension, then the transcranial approach was used. In treatment of patients with subacute clinical symptoms, also we apply high dose of corticosteroids, but then we actually apply a planned surgical treatment, doesn't require the urgent surgical treatment. As the last show, we're showing the invasive adenoma with signs of hemorrhage that was invading the cavernous sinus and had a supra and paracellular extension. These are the MRI before surgery, and after the surgery, a remnant in the cavernous sinus that was treated later with gamma knife. Thank you once again for your kind invitation, and I want to invite you to the 6th Congress of the Southeast Europe Neurosurgical Society that will be held with joint meeting with Hungarian Neurosurgical Society next year in October in Budapest, Hungary. Thank you once again.
Okay, thank you very much. Let me just get you off the screen there for a second. Okay, very good. Okay, the floor is open for questions or discussion.
I have a comment, please.
Go ahead.
Thank you for your nice presentation. I read your comments about the very little article speaking about pituitary apoplexy post-surgery as bleeding and the remnant tumors. So what's your comment for this pathology to happen post-operative?
Yeah, you're right. I didn't mean to enlarge a little bit the presentation due to time consuming, but you are completely right. There are cases that should be retreated when in remnant or residual tumors there is a bleeding. But in this large series, we encountered, let's say, approximately 2 or 3% of such cases that require urgent neurosurgical treatment, let's say 6 to 12 hours after the surgery. Yeah, especially in cases.
What's your comments for the pathology to the reasons for
all
the
of those,
apoplexy?
Yeah, all of those were invasive macroadenomas. Yeah.
Yeah. Thank you.
Thanks.
Okay, more.
Yeah, I make a little bit of a comment.
Sure.
You see what we talk about apoplexy in the tumor, and we see blood in the tumor. That is, you will see blood and cyst formation and a fluid level in the tumor that shows that this is a character of the tumor itself. It is not always that it is blood. And it is not classified into the syndrome of apoplexy. Having blood in the tumor and having a cyst in the tumor and having a fluid level in the tumor does not classify the tumor into apoplexy. Apoplexy is a syndrome. Apoplexy is a sudden acute onset of the symptoms. Many of these pituitary tumors have fluid level, have cysts, have evidence of bleeding, but that may not be classified into apoplexy. The symptom, the syndrome. The other thing is Jalal said about fatal pituitary apoplexy following surgery. This is an important issue in largish tumors. And Jalal will be happy to know that I described it first in the literature several years ago. If you go in the literature and hunt for fatal postoperative pituitary apoplexy, that was described by me several years ago. Of course, radicality of resection is necessary. Radicality of resection is important, but some of these tumors are characteristically very heavily vascular and they bleed following surgery. Now, which tumor needs aggressive surgery, which tumor does not need aggressive surgery, is a very, very critical issue in pituitary tumor surgery. This is my observation.
Thank you, Professor Gora, for your comment.
Okay, more comments from the panel?
See, John.
Go ahead, Harshad.
See, residual tumor bleeding post-operatively, it could be the vascular tumor, as Atul says very clearly. They cannot be said to be a pituitary apoplexy. Pituitary apoplexy is a syndrome where it bleeds in tumor acutely and causes the symptoms. And so these are the two different entities. And the cystic pituitary tumors are also a different entity and not a apoplexy. This is my personal view in that. And apoplexy most of the time needs an urgent intervention. Of course, sometimes you can get away without doing urgently also. So it depends on what you see. The post-operatively, I have seen this in a residual tumor causing a bleed and some patient is deteriorating and we need to re-explore. But we will not call this as a apoplexy. Thank you. This is my view.
Thank you.
Thank you. Thank you, Harshad. More comments or questions? Okay, very good, doctor. Thank you very much.
Thank you once again.